Good morning, everyone. This is Alison Malari, the Injury Prevention Officer here at Injury Matters. I might get going, still got a few people who are just joining us now, but I am mindful of time and I will get started with the presentation. So welcome to the Mild Cognitive Impairment and Falls Prevention in Older Adults webinar. So I would like to acknowledge the traditional owners of the land in which we meet today, the Whadjuk Noongar peoples, and extend our acknowledgement to the traditional owners of the land in which people from across the Strait and Australia and world actually are attending today, and would also like to pay our respect to elders past, present and emerging. So before we get going, just a little bit of housekeeping. I think everyone's microphones are to mute, but just in case yours isn't, can you please mute it? We would love to hear your questions, so we strongly encourage you to please send them through in the question and answer function, and we will go through them all at the end of both the presentations. As well, if you also have more than one person in the room attending today, can you just please send us through a private message in the chat function and let us know how many people are viewing with you. And as well, if you are having any tech issues, if you send a chat message through to Joanna Collins, she'll be able to do a little bit of troubleshooting with you and hopefully resolve those issues. So a little bit about Injury Matters. Injury Matters aims to prevent and reduce the impact of injury within the Western Australia community. We are for safer people and places. We do this through advocating and providing education for injury prevention, as well as providing support for those people who have been impacted by injury. So today's presentation is brought to you through the Stay on Your Feet program with the support of the Department of Health WA. The Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults on how to prevent falls in the community. This is done through the Move, Improve, Remove campaigns. Move your body, improve your health and remove hazards. So this presentation today is part of the Stay on Your Feet training and education for health professionals such as yourself working with older adults. So falls continue to be a huge issue in Western Australia. To put it into perspective, a person dies from a fall every 26 hours, is hospitalised every 20 minutes due to a fall-related injury, and attends an emergency department every 12 minutes due to a fall. So collectively, fall-related hospitalisations in Western Australia resulted in over 157,000 bed days at an estimated cost of $220 million. So today's presentation is on mild cognitive impairment. So mild cognitive impairment is generally defined as a significant memory loss without the loss of other cognitive functions. In recent years, there has been increasing recognition that some people experience a level of memory loss greater than that usually experienced with aging, but without other signs of dementia. As mild cognitive impairment has only recently been defined, there is limited research on it, and there is much that we still don't yet understand. Individuals with impaired processing speed or executive function are at an increased risk of experiencing a fall. Due to the role of cognitions in an individual's physical functioning, it is challenging to distinguish the role that cognition impairment alone has on an individual's falls risk. Some research findings suggest that individuals with moderate to severe cognitive impairment are twice as likely to fall than individuals with unimpaired cognition. So Dr Elissa Burton from Curtin University will be joining us today to discuss mild cognitive impairment and falls prevention in older adults further. Elissa will be discussing the impact of mild cognitive impairment on falls risk in older adults, falls risk factors in older adults with mild cognitive impairment, falls prevention interventions, and supporting older adults to reduce falls risks. So Elissa is a Senior Research Fellow at the School of Physiotherapy and Exercise Science at Curtin University. Elissa's research has predominantly focused on healthy ageing, particularly encouraging older adults to be more physically active and consider participating in strength and balance training on a regular basis. She has worked with a number of home care organisations in Western Australia and is an Australian representative on the International Reable Network, which has been led by Professor Tim Rostgaard from VIVE in Denmark and brings together many of the world's re-enablement researchers. Elissa has conducted a number of research projects with people living with dementia, and she was a successful National Health and Medical Research Council investigator grant applicant in 2019. Her project is looking to determine whether balance and walking training will reduce falls risk and improve physical health for people with mild cognitive impairment. So now I'd like you pass it over to Elissa.
Thanks, Alison. I will just try and share my screen.
Yeah, take that off me.
Is that the right one?
Looking good, thank you.
Marvellous. Thanks, Alison, and thank you everyone for joining us today. I'd like to thank Injury Matters for the opportunity. It's great to get this many people together. It looks like there's about 58 participants before I shared the different screens, so thank you for that. Feel free to ask any questions along the way, and I'm sure that Alison will bring them up at the end of the presentation and we can discuss them. And I'm also happy to have anyone else chip in at the end with answers to questions as well, because at the end of the day, many of you are out there on the coalface. So let me see if this will move forward. Yes, I'd like to make an acknowledgement of country and acknowledge the Whadjuk Noongar Nation as the traditional custodians of this land on which Curtin Perth campus is situated, and pay my respects to their elders past, present and emerging. So Alison's pretty much gone through the learning outcomes today. I'm also going to throw in a little bit of research about types of exercise that can actually help falls prevention for older people in general as well. That way we can compare that to what type of exercise helps with falls prevention with regards to people with mild cognitive impairment, but I won't be going through to the dementia stage. So I actually did a presentation on that earlier in the year, which you may be able to access with Dementia Training Australia. So Alison spoke a bit about mild cognitive impairment, but there's actually two types of memory impairment. So those with amnestic MCI and those non-amnestic. So amnestic MCI people generally have a memory impairment, and those with non-amnestic MCI will have some form of single non-memory cognitive domain impairment. These can be in single domains or multiple domains as well. Just to give you a little bit of background, with amnestic MCI, it primarily affects memory. So the person might be on the phone to a friend or a colleague, and they work out a time where they're going to go to a cafe or a restaurant, and it's going to be Tuesday, June 30 or something like that. No, I don't even know if that's Tuesday. And it's a matter of, once you get off that phone call, it's like, oh my God, when was that appointment? So it's remembering the time, the day, where we had to be. So that's what affects generally people with amnestic MCI. Whereas non-amnestic MCI, it's a little bit more having the ability to make sound decisions, remember sequencing steps, and what you can do to complete complex tasks. So for an example, I love drinking tea. So I always fill the kettle up, then I put the tea bag in. Once the kettle's boiled, I like to have the hot water in, and then I'll put some milk in. Whereas a person who may be having some difficulties with sequencing of steps, they may actually put the milk in, and then they boil the kettle, and then they put the hot water in, and then they put the tea bag in. So whereas they may have done it the way I do it for many, many years of their life, but now the sequencing of those steps becomes a little bit more difficult to remember. You probably can still drink that tea, so it probably doesn't matter in that scenario. With regards to prevalence of falls, we have so many different communities, and when we talk about older people in general, it's usually here in Australia 65 years and over. I'm a big believer that age isn't necessarily, it doesn't necessarily have a big impact on health issues, because if a person is 55 years of age and has a number of chronic health issues, more than likely they're not going to be as healthy or as physically active, or their function as good as, say, a 70-year-old who has very few health problems, is physically active every day, has been physically active all their life, and the chances are that they're probably going to live a longer life than that 55-year-old with a lot of health issues. So age shouldn't be a defining factor of an overall thing. Yes, increased age is definitely a risk factor for falls, but it's all the other things that come around it as well that need to be considered. But I'm sure I'm talking to the converted with you all. So with regards to older people living in the community, generally we say 30% of older people will fall within a 12-month period. Now, a lot of this research on older people living in the community is quite old, that 30%, but time and time again, studies actually show that it's usually 1 in 3 that will fall over a 12-month period. I did some recent research just a couple of years ago with home care services, and we had 10 WA home care organisations who were involved, and we found that 48% of their people receiving home care services were actually falling across that 12-month period. Now, there could be a little recall bias in that, but having said that, there was pretty much a replication study 10 years prior by Joanna Smith and Jill Lewin, where they went out to those 10 home care organisations and did a very similar study on the prevalence of falls, and they found the same thing. So pretty much there's a 50% increase between those living in the community and falling, and those actually receiving home care services, which in some ways is not unusual because they do have functional issues usually, or they're more frail than older people living in the community who don't actually need those services. So what is the research at the moment telling us about older people with MCI? Well, the studies really do range, and that could be a case of depending on how severe or mild the participant's MCI is and where their functional status is as well. So a number of research projects have seen between 26% through to 59%. So there is quite a big range of prevalence of falls for people with mild cognitive impairment, and they really are, when you look at this, more likely to be falling than older people who don't have mild cognitive impairment. Also remembering though that if a person is diagnosed with MCI, there is always a chance that they could revert back to not having any cognitive impairment. Yes, there is that chance that a proportion will move on to having dementia or some form of dementia and cognitive impairment, but there's always that chance also that they can revert back to no cognitive impairment. Older people with dementia living in the community, range of studies again, somewhere between older people without any cognitive impairments right the way through to 65%. And you find as a person's dementia journey goes on, often they do become frailer, their function does decrease. And very similar findings again in residential aged care. And as we know, probably about maybe 70% of older people in residential aged care usually do have dementia or some form of cognitive impairment. So what's the impact of mild cognitive impairment on falls risk? So what tends to happen is people with MCI have a higher prevalence of gait impairment. So over time, their gait will start to slow. Their stride length will actually decrease, and that puts them at higher risk of falling. And it also puts them at higher risk of having injurious falls and multiple falls as well. So the impact of mild cognitive impairment can be quite large on someone's falls risk. They also have an impairment in obstacle negotiation, so going up and down curbs, up and down stairs, negotiating different obstacles that we find when we go for a walk or try and cross the street. That becomes impaired also, and it increases the risk of falling. So some falls risk factors that the research has found for older adults with MCI is walking. As I've mentioned before, gait speed does become slower. So it's really important with your patients or your clients just to have a bit of a handle on, over time when you see them, are they actually starting to walk slower? Is their step length declining? Because these are real signs that they could be at greater falls risk. So it really is working on those things to try and keep the gait speed up, try and keep the step length at what their usual step length is. This doesn't mean increase the step length past what they're usually doing, because that can be dangerous as well. So it's trying to keep the usual what they were doing prior to having any functional issues. So slower gait speed is also associated with severe and injurious falls. So we need to be really careful that older people aren't slowing down because they have that fear of falling, and you'll often see that they start to shuffle as well. It's lifting those feet, it's keeping the step length going, and it's also keeping the gait speed going. And if you find that they are slowing down, it's working through measures to actually try and build that back up. And stride time variability is also associated with having a higher risk of injurious falls. So dual tasking also increases the risk of falls. So when we talk about dual tasking, a good example is most people know what the tug test is. So you have the person sitting down, you then are using a stopwatch to measure the time it takes for them to stand up, walk 3 meters, come back and sit back down. So it's a good measure of mobility and also strength, being able to get up off the chair. You then get that older person to actually try and do that same tug test, but this time they need to be counting, starting from 100 and counting down by sevens. And it's amazing how much slower, not even people with MCI, but in general, people will reduce due to the dual tasking. So particularly with people with dementia, if you go for a walk or you're doing activities with them, if we're talking to them all of the time, it makes it really difficult for them to concentrate, and often it's better that they concentrate on that walking skill or the functional task. Same thing for people with MCI to a lesser degree. It's really important for them to try and be doing the one task at a time rather than multiple things. And as we've seen, even younger people who go for a walk, they're on their phone, can tip over into the fountain or trip over a curb, or whatever we're doing when we're not actually concentrating on the task at hand that can be more dangerous. So dual tasking can be an issue and increases the falls risk factor. Some other factors that increase an older person with MCI's falls risk are if they have an impaired one-legged standing balance. So this woman, obviously, for the time that the photo was shot, has pretty good one-legged standing balance. But often a lot of older people with MCI, that will start to decrease over time. And then if you have greater postural sway also, then you're at increased risk of having a fall. Higher depressive symptoms and having a fear of fall can also increase your risk. So it's really important to try and improve that fear of falling and get to the crux of it and why they actually have a fear of falling. Many older people don't like going up and down stairs and also escalators as well. And I remember my grandma towards the end of her life certainly didn't like getting on and off escalators. That was a real issue for her, and particularly after she had had a couple of falls. So lower functional status and having an ability to complete those daily tasks also at a lesser status also increases someone's risk of falling. So I thought what I would do is actually go through a Cochrane review by Sherrington that looked at exercise for preventing falls in older people living in the community, just so that we can actually compare what the differences are and what we actually know for people without living with cognitive impairment. And the research now for preventing falls and exercise for preventing falls is pretty good. Like we know what works and we know what doesn't work at the moment. So if you want to use what works, the stuff that I'm going to present for you today is the stuff that you should be concentrating on for older people who are living in the community. There's 108 randomized control trials. So when we talk randomized control trial, the intervention, which is the exercise program, they want to see if there is a change and whether it is effective, is then compared to a control group. Usually that control group will be receiving standard care, or they'll be not active at all. And that way we can really compare, rather than looking at the intervention only and saying, oh yeah, it works, but doing nothing might have worked just as much. So that's why we need to compare it to doing nothing or standard care to actually see if it's better or not, because that's really important. So as Sherrington and her colleagues found, 23,000 participants across 25 countries. So you can be pretty sure that the research here knows what it's talking about. Average age is 76 years and almost 3/4 of women. pretty much all of my research I do with older people, and predominantly they have older women in that research, often because 1 in 2 older women, when you get right to the other end and above 80 years, tend to be more women alive than men. So there are 81 trials that compared exercise to a control group, and Sherrington and her colleagues have stated that with high certainty, so this is looking at the quality of the evidence with those randomised control trials, whether they had blinding of the assessors, whether the randomisation was done correctly, those type of things were looked at in the quality, and they can be really sure that exercise reduces the rate of falls by 23%, which is great to hear. And that exercise reduces the number of people falling also by 15%. But here's the really big one that often we kind of go, okay, we just need to exercise then. Balance and functional exercise reduces the rates of falls by 24% and the number of people experiencing a fall by 13%. Now we can be really, really certain that if you get someone to be doing balance and functional exercise on a regular basis over the long term, a bit like brushing your teeth, regular basis, long term, then they will reduce their rate of falls, and they will reduce, it will also reduce the number of people experiencing a fall. So it's really important that we understand that balance and functional exercise is the big winner here. Now with moderate certainty, so the quality of the studies wasn't quite as high as what it was for those balance and functional exercise RCTs. When you include balance and functional exercise, plus you include strength training, you will reduce the rate of falls by 34%, remembering that the certainty of the evidence isn't quite as high. So we definitely know that balance and functional training works. Strength training, added bonus anyway, that it certainly helps function. And who wants to be helped up off the toilet? So strength training is hugely important with things like getting up on and off a chair, getting in and out of the car, living independently. It is very important. When it comes to strength training, it needs to be combined with balance and function in order to actually reduce falls in older people living in the community and the number of people experiencing a fall. Tai Chi has a reduced rate. It does help to reduce the rate of falls, but the evidence is not as good on the quality of the studies. But we can be very sure that it reduces the number of people experiencing a fall. So a big thing with this is if you enjoy doing Tai Chi, then go out and do Tai Chi. So it is a form of balance training, but balance and specific balance and functional training will be more effective. One thing to consider also, there's many strength training programs and community programs that are targeted towards older people living in the community. Many of them have a really big strength component, and then they might whack on like 5 minutes of balance just at the end, just to say, yeah, we add balance into it. If you're delivering some of these programs, if you can make the balance component and even some functional exercise components bigger in that session, then that really would be beneficial. In a previous study by Sherrington and some other colleagues, she did a systematic review and a meta-analysis, quite similar to the Cochrane review, but she also identified that around about 50 hours of balance training was sort of like the magic number, if you want to call it that, that you need to get to in order to see that prevention of falls. So 50 hours doesn't have to be in 1 month. 50 hours can be across a number of months, which would be great. And then hopefully by that point in time, the behaviour and the habits have been formed, and the older person will actually just keep going with the balance training and functional exercise training, because it's really important. What we can be sure about as well is at this point in time, the evidence is really uncertain about strength training by itself. So that's why I recommended that if you're delivering a community-based strength training program to older people, please include some balance training as well. That's really important. Evidence is still uncertain about dance and also about walking programs. There was a walking study a number of years ago that actually increased the number of falls rather than decreasing them. So we're still uncertain about that. One thing to note with regards to this Cochrane review is people living with MCI or dementia were actually excluded from these findings. So if they're excluded from the findings, what actually helps people reduce falls who are living with MCI. So at the moment, there's no systematic review that has specifically looked at this. And so I've looked at a few recent interventions because, as Alison said, research with people with MCI is actually pretty new, and there's not a huge amount that's out there, and particularly looking at falls prevention. So this first study, they actually had 40 people in each group, and everyone had MCI, which was great. And interestingly, they looked at fear of falling and risk of falling. Now, one of the reasons for this is when you have 40 people in each group and you're looking at a rate of falls or the number of falls or the number of people falling, that's just not enough. So most of the studies that were part of Sherrington's Cochrane review and the large fall studies for people living in the community, you need somewhere between 300 and 400 people, a couple of hundred in each group, and you need to look at it across at least 6 to 12 months in order to determine whether the rate of falls and the number of fallers and injurious falls as well has actually decreased in the intervention group or not. So studies with really small numbers are not actually going to show an effect or a true effect for rate of falling. So this study looked at cognitive training and balance versus balance training only. They had the 20 sessions twice a week, which was great, which included cognitive training. And then they included 30 minutes of balance training every day for 10 weeks, which is absolutely brilliant. So they're clocking up towards the 50 hours in this study, which is good. And they found that cognitive training had significant improvement in the tug, dual tasking, and they improved their balance, which is great, but there were no differences in fear of falling. And once again, the study didn't look at rates of falls. So just when we're talking about falls prevention, you have to interpret these results cautiously. And also, they weren't looking at rate of falls. Miramal and their colleagues had a 6-month follow-up to their randomised control trial, and they had decent numbers, 126 in the intervention group, 119 in the control group. The only problem was they had a couple of subgroups. So 20 people with MCI in the intervention, 23 with MCI in the control group. They also had a couple of groups with Parkinson's disease as well. So once again, they're not able to actually look at the falls rate for those two subgroups because the numbers are just too small. But they tested out a treadmill training, which included virtual reality, and it had an environment designed to reduce falls risk. So remembering back with looking at missing out on things and watching you step over curbs and stuff like that, that was part of their virtual reality. And it progressed over time, which was really good. The participants came in and did it 3 times a week for 6 weeks. And the falls rate after the intervention was completed, there was no difference between the two groups. Not really surprising with small numbers like that. So they may have found an effect across the whole intervention, but that would have been with some people who didn't have MCI as well. Schwenk has done a few studies on MCI, and with this study, they were looking at Amnestic MCI, and as you can see, it was just a very small pilot, probably to see whether it was feasible and safe and how it worked. And they had 12 people in the intervention group doing the balance training, and they had to wear some sensors. They had some virtual obstacle crossings as well, and they were also looking at weight shifting. And the control group was not active, so they basically signed up and didn't have to do anything. They went twice a week with their sessions for 45 minutes, and it only went for 4 weeks, so it really was just checking how the intervention ran and whether any issues were coming up or not. They did see a significant difference in sway and also in fear of falling for the intervention group, but again, it's really small numbers. Sunkarat did their RCT for 15 weeks, and it was based on Tai Chi. So they actually had the participants go into a centre for 3 weeks, and then they had to do 12 weeks of home-based. But they were getting it up there. They were doing 50-minute sessions, and they were doing it 3 times a week. And the control group was just receiving cognitive and falls prevention information. They had people with multi-domain amnestic MCI, and again, pretty small groups, didn't look at falls rate again, but they did look at falls risk, and they moderately reduced that falls risk. This one's quite an interesting one by Lepardo. I found this, and it's actually a study protocol. So what happens is when you're doing a large randomized control trial, to reduce the amount of bias that is involved in the results, it really is gold standard to actually publish a study protocol. And that just shows exactly what you're wanting to do, what your sample size will be, what your intervention will involve, when you will do your assessing, and in this case it was a baseline 3 months and 6 months, what your outcome measures will be. And for this one, they're talking about falls rate and falls risk are their primary outcome measures. And Lepardo and his colleagues have said that they're hoping to recruit 93 people with mild cognitive impairment, which is really interesting when the primary outcome is falls rate. As I've said before, you need sort of around 300-400 people to actually see something effective. They've got 4 groups, so 3 of them are intervention groups. One group will be dealing with physical training, and will be multimodal, so they'll have flexibility, endurance, strength, and balance training, and they'll be doing it 3 times a week for the 3 months. And then there's a cognitive training group. They'll do it the same amount of time for the 12 weeks, and then there's a physical and cognitive training group. So both of those are combined in together, and then the waitlist group will just be doing nothing. Now, I was quite interested to see what they base their sample size on, because 93 people is not a lot of people for a falls rate study. And when I went back and had a look in their study protocol, they actually based the study sample size and their calculations on changing gait, not actually changing falls. So I'm not 100% convinced that they will actually show an effect for their different interventions. If they were looking at a primary outcome of changing gait, then more than likely they would see. But time will tell. I could very well be proven wrong. So I'll be interested to see the results once they've finished their randomized control trial. So what do we know from all of this? Well, what we know, unfortunately, is that there's currently no randomized control trials with high quality study design that have looked at reducing falls for people with mild cognitive impairment only. So some have had like little subgroups in, but no one's actually looked specifically at MCI. There are studies certainly with people with dementia or Alzheimer's disease, but not specifically with MCI. And the studies that I've shown you today are pretty small sample size, and the intervention period's quite short. So we really do need to be looking at some studies for at least a 6-month intervention and having a look at the falls rate over 12 months to see if there really is an effect. So I thought what I'd do next is, because I'm not 100% sure if you all realise that there are actually physical activity guidelines for people with MCI. So I thought I'd have a look at the physical activity guidelines for older Australians in general, and then we'll have a look at those for people with MCI. The Australian guidelines are pretty wordy and not as specific as some of the other countries like the US and Canada and the UK, where they actually give you a little bit more specificity when it comes to how much strength and balance training you should be doing. So for the Australian guidelines, older people should do some form of physical activity. Doesn't matter about your age, your weight, your health problems, your abilities, you should be doing something every day. And then they go on to say it would be great if you do something that helps improve your fitness, your strength, your balance, and your flexibility. This is where they get a little bit more prescriptive, which is good, that you should accumulate 30 minutes of moderate intensity physical activity on most days. Check. Most people know this one, but most people go, okay, I've gone for a walk for 30 minutes, I'm sorted. But unfortunately, when it comes to falls prevention for older people, going for a walk every day is not going to actually assist them with regards to falls prevention. So when it comes to the US, the UK, Canada, and many other countries around the world, they actually include now at least 2 strength and balance training sessions per week are required. So it would be good if once these physical activity guidelines are updated, who knows when, but it's a little bit more prescriptive on that one. That would be really good, because then it would be much clearer for older Australians. Those who have stopped being physically active, it's a really good idea to start slowly when you're getting back into physical activity. Delayed onset muscle soreness, DOMS, can be a killer for some people. I know once I have a 2-week holiday where I often will go and travel overseas, not this year, but often in previous years. And then I come back and I get into my strength and balance training, which I usually do on 4 mornings, and then I'll do cardio another 2 mornings. The DOMS is crazy on the first couple of weeks. So it's amazing how just having 2 weeks off where all I'm doing is walking around different cities of the world and having a look at nature and all that sort of thing. It's amazing the difference between doing that and then going back to a strength and balance session. So it is important to ease older people in slowly. Otherwise they will feel those DOMS and go, I'm not going to do this anymore. And those people who have been doing vigorous physical activity all their life, and there are many older Australians who have done that, they just need to be congratulated and continue to be motivated to actually continue doing that. They shouldn't be discouraged from continuing their vigorous physical activity, especially if they've been doing it most of their life. So the physical activity guidelines for people with MCI were developed by Nicola Lautenschlager in Melbourne and her colleagues across Australia in 2018. So how do they differ from older people who don't have mild cognitive impairment? So there's a number of recommendations that Nicola has. And the first one is that you should be doing moderate intensity aerobic physical activity, at least 150 minutes per week, which is pretty much the 30 minutes a day on most days. Or if you're into vigorous intense activity, then you only need to do 90 minutes. Now, the evidence shows that this definitely benefits brain health and function, and there's strong evidence for people with MCI. So if you are treating people with MCI, please encourage them to be doing the 150 minutes of moderate intensity aerobic physical activity. That's a minimum. So if you can get them to be doing even more, fantastic. It's certainly going to help their brain health. Progressive resistance training twice a week. Love the fact that Nicola and her colleagues have been really prescriptive on this one. And that's on top of incidental activities. So if you're going to do food shopping, getting the big bags out of the car, bring them in and plonking them on the bench, that's your incidental activity. You then need to be adding 2 strength training sessions a week. The evidence isn't quite as strong as what it is for aerobic exercise, but we do know that it does benefit your brain and physical health and function for older people with MCI, so this one's definitely encouraged. The third recommendation is to encourage older people with MCI to actually be doing balance training each week. The big thing with this, though, is as we've seen today, there's no actual research trials that have examined balance interventions specifically for people with MCI. So this recommendation, unfortunately, is extrapolated from older adults. So we really do need to be getting in and doing some trials that are large and look at falls rate that are looking at balance for people with MCI and whether they can reduce falls risk. The fourth recommendation is that whatever you're getting your patients to do, it should be individually tailored according to their health problems, physical capacity, and also the environment to try and make it as easy as possible. Nicola and her colleagues also suggested consulting with a healthcare professional before commencing physical activity. I've done many studies with home care clients, and whenever we have gone to the GP or a healthcare professional to ask if it's okay for their patient to actually be involved in our intervention, every single time they have said yes. So it's pretty rare for a GP not to encourage an older person to actually be involved in an exercise program, which is great to see. And it definitely needs to be simple and safe for the person and just make it easy. So with my trials, I very rarely get people to come into Curtin because the transport and the parking are a nightmare. So we usually try and come out to the older person within their home or somewhere where they enjoy being so that we can assess and give them an intervention, just simply to make their life much easier. So what do we recommend? For people with MCI, definitely walking every day, or doing some sort of aerobic activity, swimming, cycling, whatever they enjoy that's an aerobic activity. And also including that strength, balance and flexibility on a regular basis, at least twice a week it needs to be, until we know more. So that brings up to an opportunity at the end. As Alison said, I was lucky enough to receive an NHMRC investigator grant, and I'm actually now looking at balance intervention, which is included with a walking program. And the walking program is simply because we know that improves cognition for people with MCI. So ethically, it seems wrong to actually not include that within the intervention. And so we're going to be doing a balance intervention that was developed by a physio in Queensland, Meg Lowry, and we're going to be looking at falls rates over 12 months. The intervention will be 6 months long, and we will have intervention and control groups. So people in the study will be aged 50 years and over with my MCI. They'll be living in the community and not physically active or doing regular balance exercise. So at this stage, I'm getting ethics approval from a number of ATREC committees, and hopefully in the next couple of months, we'll be able to start recruitment. And we have a number of memory clinics on board and the aged care rehab clinic at Rockingham Hospital. Alzheimer's WA have agreed to be a partner, and memory cafes are also going to be asked if they have any people who would like to participate. I'll be starting up a Facebook page and trying to get publicity through different newspapers and social media, and also Curtin FM radio. I realise that most of you are actually helping people with MCI every day. And if you have any other ideas for how I can recruit these older people into my study and to try and help them reduce their risk of falls, it would be great to hear from you. If you think that a couple of your patients might be applicable and it might be a perfect opportunity for them, there's absolutely no cost to them whatsoever. They won't be paid either. And the assessors and the physiotherapists who will be delivering the interventions will actually go out to their home. So I would love to hear from you if you have some ideas for recruitment. It'd be great. Any of the references as part of the studies that I've spoken about today at the back here, and I'm sure Alison from Injury Matters would provide you with a copy of my presentation if you're needing it. So they're the different ways that you can get in touch with me, and I would love to hear from you as well. So thank you for that.
Great, thank you so much, Elissa. That was such an informative and practical presentation as well. I think there's quite a few take homes there that people can go back out into the community and implement with their clients or their patients. So thank you. I have had quite a few questions come through. I've had, I'm not sure if you can see them.
I'll stop sharing my screen. So
here we go. I'll pull mine back up. Give me 1 second. Here we go. I do have a couple of questions. So I have a question from Monique, or two questions from Monique Curdian. She says, hi, in the treadmill and VR study, what were the interventions, please? Was it VR only, treadmill only, or treadmill plus VR?
Monique, I'm pretty sure that it was treadmill plus VR. So they're on the treadmill doing the VR. But I'm very happy to also send that study through to you if you send me an email.
Great, thank you. And another question from Monique as well. Is there much evidence for improving balance in older adults? So with MCI and non-MCI using VR?
Well, there's a couple of studies looking at the actual improving balance, remembering that they're really small sample sizes. Now with my searches, I wasn't looking specifically at balance. I was looking at reduction in falls, and these people tend to have balance interventions. And we also know that for older people who don't have MCI, that balance is how you can balance and functional exercises, how you can reduce falls. But VR, it's quite new. So there are not that many projects that are out there, studies that are out there, but it's emerging. So I wouldn't mind betting that in the next couple of years there's a lot more, particularly given that people have been working from home in COVID, and some of the coders might have actually had more time to actually develop a little bit more on the VR side of things. So it's an interesting space that is very new.
Great, thank you. Monique has sent through her email address, so I'll send that through to you afterwards, Elissa.
That would be great, Alison. Thank you.
I also have a question from Liz Clark. She asks, she assumes participants must be in WA for the study.
Yeah, that's correct, Liz. Yep. Yeah.
Are you aware of, I guess, any other studies that might be happening in other states where people could recommend clients or patients to?
Not with people with MCI that I know of, but that doesn't mean they're not happening. They very well could be.
Yeah. Great, thank you. And I have a question from Stephanie Fullerton, who has asked, what is the best diagnostic tool for MCI? Wondering because standard cognitive screen seems to include only a small section for recall, so scores can look quite good overall.
Yeah. Hi, Steph. How you going? Steph's been a physio part of many of my projects, so it's good to hear from her. With regards to the inclusion criteria for my study, we're looking at using CDR and having 0.5, and also we're looking at having MMSE, and there's also a number of different screening tools as well, because how much alcohol is drunk can also affect a diagnosis of MCI. Depression levels can also affect diagnosis of MCI as well. So we will be using the geriatric depression scale. So there are a number of diagnostic tools that we're using in order to have people in our inclusion criteria. We're also, with regards to the memory clinics, if they've had a diagnosis of MCI from a geriatrician, they will also be included. And I know some of the geriatricians use different tools to those. So, and they use different tools to each other as well.
Great, thank you. You did just touch on this briefly then, but I've had a question come through from Katrina Wald, who's asked, is it sometimes difficult to distinguish between MCI and depression, as symptoms can be similar?
Yeah. So what will happen is if they hit a certain level on the GDS scale, we'll actually say to the participant, would you mind if we call you in 3 months? And we've just had this reading on the GDS scale, so we would probably recommend that you have a bit of a chat with your GP, see how you're feeling, and if we could call you back in 3 months, we'd really appreciate it. So yes.
Great.
Hopefully that answered that.
Another question from Nicole Vitali, who has asked, are there any actual resources that outline specific useful exercises to try for falls prevention with his clientele?
No, because we don't really know what works yet.
Yeah, okay. Hopefully so.
So at this stage, your best thing would be extrapolating to people without MCI.
Yeah, great, thank you. Question from Kylie Humrick, who has asked, what flexibility exercises are best? How much time would they spend doing these?
Are you talking for falls prevention, Kylie? Because flexibility exercises don't really help with falls prevention. Flexibility can just help to keep a person supple. And often what will happen is doing functional tasks, even like getting off the ground, if that person's not flexible enough, as well as strength of being able to bring through the hips, if they also don't have the flexibility of being able to move the joints enough, then often that can be prohibitive for them getting off the ground. So flexibility in exercise is almost more of a, there's not a lot of research out there that it's beneficial, but it's more for keeping the pain levels down and just keeping supple. So, and it all depends on where someone is really tight. If they're sitting a lot and not actually doing an awful lot, then I would suggest that pretty much flexibility anywhere would be good, really. because often the lower back will get sore, the hip flexors will be tighter if they're doing a lot of sitting around and not a lot of walking. So it all depends on the person in that regard. But as far as falls prevention goes, flexibility doesn't necessarily make a huge difference.
Great, thank you. Question from Fiona Gray. She has asked, are there any plans to recruit from residential aged care facilities or just in the community at present? And that's in regards to the study.
Yep, just in the community at present, rather than people in residential aged care.
Yeah, thank you.
Could be a future study.
Watch this space. Question from Bobby Lassiter has asked, may I have a copy of the program presented? Is that, I guess,
in the slides?
Yeah, the slides.
Yeah, I'm happy for anyone to have the slides. That's no drama.
Yeah, sure. Question from Paula Snow. She says, hi, Elissa. I work in ED in a transdisciplinary OT-PT team. We started using the stage 4 balance test as an objective measure of balance given the constraints of the ED environment. Thoughts?
Yeah, tests are hard, you know. It's just like, it's like people love doing things like the tug test, and tug's great because it's simple, it's easy, but often you don't necessarily see a change when it comes to research. And I'm more of, I choose measurement outcomes based on what my research question is and what I'm wanting to find out. Paula, with regards to what you're doing, it's a matter of choosing the test that you feel helps you most answer whatever your goal is for your patient. So what is your reason for doing the balance test? Is it simply to test their balance? Is it to have a look at falls risk? I presume testing their balance is a really good reason why you do a balance test. But you need to know the reason why you're wanting to do it, and then if that test is actually measuring what you want to know with the person. So I use different balance tests depending on what the population is, what my intervention is. So it's hard to say that there's a one size fits all. I reckon if I lined up 10 physios and OTs, they'd probably tell me 10 different balance tests that they all love. And maybe they use 3 different balance tests for 3 different occasions as well.
Great, thank you. Paula just said, it seems to have helped build awareness of balance impairment for the patient and willingness to attend the falls clinic.
Sorry, Alison, can you repeat that?
Oh yeah, sorry, Paula just texted through. It seems to have helped build awareness of balance impairment for the patient and willingness to attend the falls clinic.
Perfect. Well, I would say if it helps their knowledge of their own balance and their willingness, use whatever works.
Yeah, great.
That's what I do.
Yeah. And then she's also asked, does falls clinic attendance exclude someone from your study?
If they're going to be attending the falls clinic for a large period of time, but once they've finished their falls clinic attendance, then they can be part of the study.
Great, thank you.
As long as they're, of course, not doing, they haven't done like 50 hours of balance training in the last month or something like that, those physical activity things. And if they're doing 300 minutes of physical activity a week, then, and they're going to continue with that, then they would be excluded from the study based on the physical activity stuff rather than being at a falls clinic.
Sure. And I have had quite a few requests come through for the slides. So just letting everyone know that I'll send them through over the coming days for everyone. You don't need to personally request them. They will be going out.
And if anyone needs, if you find that you've looked at the references at the back and you have a question about them, send me an email and I'll help you out.
Great. I think that's all the questions. So thank you so much, Elissa, just for taking the time today to share your wealth of knowledge and experience with us, and good luck with your study. I know the team here at Injury Matters is really keen to keep in the loop and hear how things progress and some of the developments that you start to make as the study starts to roll out.
Thanks so much, Alison. And Injury Matters are actually one of my partner organisations, part of the project, and it's really important having great organisations like yourself involved. So thanks for the opportunity. Really appreciate it.
Great, thank you, Elissa.
Oh, there's a couple more questions.
I missed them. Hang on one sec. Where are they?
Monique, that would be fabulous if you could promote it. Would you mind sending me your email, Monique, and we can then go back and forth?
Yeah, perfect. Thank you. And I have also asked someone here, will the video be on the Injury Matters website? It will be on the Stay on Your Feet website. So I'll also send out a link for that one afterwards as well, once we've had time to upload it. Great.
Great.
All right. Thank you.
Thank you very much.
Yeah.
Thanks everyone.
Great. All right. So just looking at next steps following on from today's presentation. There are a few Stay on Your Feet activities which may be of interest to some of you listening today. So Stay on Your Feet does have our Connected program. So Connected provides you with the opportunity to build your professional network and to keep you engaged in today's conversation. So Connected is a networking program whereby participants are randomly paired bi-monthly to have a 15-minute conversation with another professional. Stay on Your Feet also has an e-directory. So it's an online directory of WA programs, services and events which help older adults to either move their body, improve their health or remove hazards. This can be exercise classes, social groups, cooking classes, etc. So if you are interested in promoting your exercise class or any of your programs or services, please jump on the Stay on Your Feet website and register. We also have an e-learning, so it's a free self-paced online learning. There are 2 online modules which have been developed for exercise and activity coordinators who work with older adults. It provides support for those wanting to increase their understanding of exercise for falls prevention. The modules are interactive, practical and evidence-informed and will assist you to facilitate effective and relevant falls prevention exercise strategies for older adults. After completing the online course, you also receive a certificate of completion for those of you who are looking to claim extra CPD points. So we also have the Stay on Your Feet e-news, which is a monthly newsletter that includes information on falls prevention, research, as well as upcoming events and training. So I encourage all of you to jump on the Stay on Your Feet website and sign up if you haven't already. And lastly, the Community Falls Network. We have another meeting coming up in August this year, and it's a group that aims to, the Falls Network group aims to bring together a variety of health and community professionals to discuss key issues and share solutions in community falls prevention. As well as those activities, there's also some really great Stay on Your Feet resources available. We have everything from how to get up off the floor to medications, fueling your body, as well as strength and balance resources. And if you jump on the website, there's a couple of different videos as well that you can access. Stay on Your Feet events and training. So today wraps up our events and training calendar for the 2019-20 financial year. But you can get on the Stay on Your Feet website and view some of the previous webinars that we have completed from earlier on in the year, and a new training calendar for the 2020-2021 financial year will be out shortly. So we'll send out more information in the Stay on Your Feet e-news as those events are organised. So once again, the biggest thank you to Elissa for taking the time to share your knowledge, your wealth of knowledge with us today. There's some really great take-homes from that that I know we all are able to pull from your presentation. And thank you to everyone else for coming in and listening. And yeah, if you here are Injury Matters contact details if you want to reach out to us, and I will send out the presentation slides following the presentation. Once you do close the webinar as well, a SurveyMonkey link will pop up. So can you all please just take a few moments to complete an evaluation. Your feedback really helps ensure that we're delivering professional development opportunities for you that are meeting your needs. So thank you. And that is all for today. Thanks.